Hello, let's talk about the thymus. This is a small organ that's a little south of the thyroid in your anterior mediastinum, and it functions as T cell school. It educates T cells and matures them and then sends them out into the world of the peripheral blood to function as T lymphocytes. So the thymus is nice and large when you're a kid, and then it involutes with age and just kind of turns to fat, parallel to the process of immunosenescence. Remember, your bone marrow also kind of turns to adiposity as you age. And so the thymus involutes through apoptosis. Of great importance is that the thymus is embryologically derived from the third and fourth pharyngeal pouches. And that last word is the kicker there, because you also have pharyngeal arches and pharyngeal clefts, but we are not talking about either of those structures. We are talking about pharyngeal pouches, which are on the interior of the developing embryo. So the third and fourth, that's where the thymus comes from, and also the parathyroid glands that will pop up later. Now, little baby T cells are born in the bone marrow as stem cells. They get a little bit of IL-3 sprinkled on them, and then a few other growth factors and cytokines. And then eventually you have a pre-T cell that's ready to enter T cell school. So you put it in the bloodstream, it rolls around to the thymus, and it enters the thymus where it undergoes its tuition. So that's why you see in the thymic cortex a ton of immature T lymphocytes. They have not been tested yet. They haven't taken step 1 or step 2. So the cortex is where they take step 1. They undergo positive selection. And positive selection means they're selected for. So they take a test. What's the test? Okay, every T cell has to read. They got to learn how to read. What do they read? They read MHC. That's the language of antigen presenting cells. You got macrophages, you got dendritic cells, right? You got Langerhans cells in the skin. They all speak the same lingo, right? And so T cells got to be able to talk the talk. So positive selection in the thymic cortex is where they learn language. Now, if they can't speak it, if they just can't remember the words, or if they stutter a little too much, they're out of there. There's some apoptosis and that T cell's gone. So then the T cells get a little bit older, they study up, they're really learning about all these different proteins in the body, because that's their job, is to recognize all the different proteins of the body. Just like we are getting educated as medical students on how to recognize diseases, T cells are getting educated on how to recognize proteins. So eventually, after they study a whole lot, after their dedicated period, they're going to take step 2, and then they're going to have negative selection. So negative selection means they are selected against. They're tested again one more time before they're mature T lymphocytes, before they get their degree. What's the test? Well, you show them. Epithelial cells do this. Epithelial cells administer the test. Medullary thymic epithelial cells, or MTECs. I know you recognize that. MTECs will show T cells all sorts of different proteins. And these proteins get presented to the T cells, like baby Simba, they get presented to the T cells on MHC. So any T cell that binds to MHC and won't let go is going to fail the test. If a T cell grabs that self-protein and says, oh, I know this is a bacteria, I know it is, I can tell this is Pseudomonas, it's got to be, then that T cell is never going to make it into the bloodstream, because you don't want that T cell in the bloodstream. Because as soon as that T cell sees the self-protein that got it so triggered and agitated, then it's going to mount an autoimmune response against your own tissues. You don't want that. So any cell that fails negative selection by binding too tightly to MHC is going to commit apoptosis. So that's selection. Positive occurs in the cortex, negative occurs in the medulla. They both involve epithelial cells of the thymus. Let's talk about some pathology. Thymic hypoplasia. What is that? failure to grow to an appropriate size, to an appropriate degree of cellularity. We've got DiGeorge syndrome, which is a 22q11 deletion syndrome. That means specifically on the Q arm, the 11th region of the Q arm of the 22nd chromosome is deleted. And when it is deleted, you get DiGeorge syndrome or velocardiofacial syndrome. So one of these two things. DiGeorge syndrome is a failure of the thymus to grow. So you have a T cell deficiency, a low T cell count. Your B cells are going to be cool. You're going to have an appropriate number of B lymphocytes because those come from your bone marrow. And you're going to have a cool number of macrophages too, right? Monocytes, eosinophils, because those do not mature in the thymus. Only T cells do, so it's the only cell type that's going to be low in DiGeorge syndrome. Now, let me tell you, the thymus is derived from the third and fourth pharyngeal pouches, as are the parathyroid glands. So if you have a small thymus, you're also going to have small parathyroids in this syndrome. And if you have small parathyroids, you have hypoparathyroidism, which creates hypocalcemia, which creates seizures and tetany and hyperreflexivity. So that's how the patient with DiGeorge syndrome will present very often in question stims and in real life with signs and symptoms related to hypocalcemia from a small parathyroid gland. So there's a great mnemonic for DiGeorge. It's catch 22, the 22 referring to the 22nd chromosome, Q11 deletion, catch standing for cleft palate, abnormal facies, thymic aplasia, conotruncal heart defects, and hypocalcemia. So when we say conotruncal, what's that mean? It means like truncus arteriosus or transposition of the great vessels. So let's take a look at a practice question. You got a 3-year-old girl in the outpatient clinic who has had white plaques in her mouth since birth and has had surgery to correct a heart defect. She's not taking any medication. Her vitals are pretty normal, a little tachycardia. And she's got these scrapable white oral plaques. So you're suspecting Candida. Now, microscopy confers that, but there's also a couple extra symptoms. When you try to take the patient's blood pressure, you put the cuff on, her left wrist spasms. What's that called? Trousseau sign. So that means there's hypocalcemia. You're hyperreflexive. It's easy to get a muscle contraction. Thymic shadow is also absent on chest x-ray. So in this scenario, they just give you the diagnosis. It's DiGeorge syndrome. Here's another question. A 3-day-old boy, very young, being evaluated for a suspected seizure. We're thinking the hypocalcemia there as a result of the small or absent parathyroid glands. So the kid's being worked up for a seizure. He had a tonic-clonic seizure lasting 40 seconds. Baby is noted to have been born with a cleft palate. Physical exam shows unilateral incomplete cleft palate. And furthermore, a 2 out of 6 systolic murmur is detected and is best heard over the pulmonic area. So conotruncal heart defects, you've got truncus arteriosus, you've got transposition of the great vessels, the pulmonic listening post on the left side at the second intercostal space is going to be a great place to hear those sorts of abnormalities. So they're giving you a great many features associated with DiGeorge, and then they ask you, the kid's deficits have arisen from abnormal migration of cells from which of the following structures? And here's the question. A lot of different combinations of different pharyngeal structures. So notice that there are pharyngeal arches. There are pharyngeal clefts. But when it comes to DiGeorge syndrome, the only one you care about is the pharyngeal pouch. specifically the third and fourth pharyngeal pouch. It's the very first sentence in this SDL. So, I mean, they're going to ask it to you, you know, because they want to see who read the very first sentence of the SDL. I mean, it's the oldest trick in the book if you're writing a test, right? So that's DiGeorge syndrome. Remember that hypocalcemia that can create seizures and tetany and a Trost sign too, right? If you tap the facial nerve. And absent thymic shadow. So those two things, thymic shadow and parathyroid problems, are going to differentiate DiGeorge from velocardiofacial. So velo means soft palate. So these patients also have a 22q11 deletion with a cleft palate and an abnormal facies. But unlike DiGeorge syndrome and velocardiofacial syndrome, you have a thymus. So there is a thymic shadow, and you have normal serum calcium because the parathyroids are cool. So that's what separates these two deletion syndromes. Thymic cysts, you guys will understand that. Thymic hyperplasia. What is this? The thymus is highly cellular. This one is good. All right, pay attention. This is really important, yo. This is very important. Follicular lymphoid hyperplasia is B cells in the thymus. They are in germinal centers and they're activated. So they're secondary follicles that are creating antibodies actively. What are they making antibodies against? This is important. Acetylcholine receptor, thus giving the patient myasthenia gravis. How's that present? Typically unilateral or bilateral, facial palsy, droop, eyelids go down, eyebrows go down, corners of the mouth go down. You get proximal limb girdle weakness that'll spread out and get worse distally over time with an inability to or a defunction in performing activities of daily life, such as combing your hair, washing your face, etc., anything involving pulling your arms up. That's myasthenia gravis. Why do you have this? Well, it's an autoimmunity against the acetylcholine receptor, which is found at the neuromuscular junction, which is what has to be active anytime your brain wants to tell any muscle to contract. So the neurotransmitter involved there is acetylcholine. So you have an autoimmunity against the acetylcholine receptor. That neuromuscular junction is very inflamed, and it's tough to get a contraction out of it. So that's your muscle weakness in myasthenia gravis. So the last question that we really have before we know this whole thing is, what's making the autoantibodies? So it's the B cells inside the follicles of the thymus that are usually making these antibodies against myasthenia gravis. Here's probably the most important thing I'll say. They want to ask you a trick question, right? They want to give you a patient with obvious myasthenia gravis, and then they want to tell you there's a big thymus. Maybe you palpate a lump on the thymus. Maybe it's lumpy, there's multiple lumps. They're going to try to get you to say that the benign thymoma, thymic cancer, is responsible for this patient's myasthenia gravis. But this SDL is telling you that 70% of myasthenia gravis patients have thymic follicular hyperplasia, meaning that the most common cause of myasthenia gravis related to the thymus is B cells making antibodies, not cancerous epithelial cells, okay? So you're going to get this question. Patient's got myasthenia gravis, they've got a bumpy thymus, and it's going to be due to the B cells. So myasthenia gravis, we treat it, severe cases, with thymectomy because it is so often due to thymic causes. And thymectomy is curative about 1/3 of the time. Now let's talk about true thymic hyperplasia. It's just a morphologically normal thymus that's large for the age of the patient, and it's got normal thymic architecture and immunohistochemistry. So if it's just a big old thymus and nothing else is wrong with it, you can just cut it on out. There you go. So it might be mistaken for a thymoma or even a lymphoma because Hodgkin's lymphoma and nodular sclerosing variant does also like to present in the anterior mediastinum. So still got to work it up like anything else, any other anterior mediastinal mass. Mediastinal mass is a bad dude. So even if it's a fibroma or a lipoma, you want to rule those out or rule out the big bads. So that's true thymic hyperplasia. You also have thymic rebound hyperplasia, and rebound is just going to be like you get cells grow and divide in response to stress. That's all this is saying. If your thymus gets stressed, it's going to respond by growing bigger. What could stress your thymus? Radiation therapy or chemotherapy for a previous mediastinal tumor, such as Hodgkin's lymphoma. So that's the most common cause of this thymic rebound hyperplasia. Is it's a patient who had some sort of lymphoma, or maybe tuberous sclerosis, I suppose, would be another fairly common cause of a mediastinal mass that you need to take out, because it's right next to the heart, right? And so if it gets pretty big, you got to take it out. And so maybe you take out this cancer, this nodule, or maybe you radiate the lymph nodes and the thymus gets a little damaged in the process and it swells up. That's all that's going on here. So there's a prior exposure in this patient that you don't see in true thymic hyperplasia. Thymic tumors, let's talk about. The thymoma is a benign tumor of thymic epithelial cells, not lymphocytes, epithelial cells. Now, these tumors histologically contain immature T cells because that's like all that there is in the thymus. It's inevitable that the tumor is going to overlap with some T cells as it grows. So this is an anterior mediastinal mass, and another common anterior mediastinal mass, again, is going to be nodular sclerosis variant of Hodgkin's lymphoma, which has characteristic Reed-Sternberg binucleate owl eye cells that stain positive for CD15 and CD30 and have a predictable pattern of spread. There are a couple of World Health Organization histopathologic types of thymomas. We classify thymomas based on their histology because you can't have a definitive diagnosis until you take the biopsy. So because you have to biopsy it, and that's how you make the diagnosis, that's how we're going to learn them. Now, you've got a type A and a type B, a few type Bs actually, and a type AB. So you've seen this before. It's just like blood groups. If it has an A in it, a type A or a type AB, what that means is that this thymoma is going to have spindle cells under the microscope. What does a spindle cell look like? Well, it's going to be sort of an elongated oval. It's going to look like a pair of lips, actually, because it's going to have some corners on both ends. It just tapers at the poles of the cell. Let's draw a little nucleus in there. So that is what a spindle cell looks like. Fibroblasts are spindle cells, okay? Smooth myocytes are spindle cells. You know exactly what that looks like. Versus a polygonal cell. Polygonal, many-sided. So here's a nice hexagon. That's a pretty orthodox polygon right there, Maybe not the one I drew, but you get the gist. So those two cells look nothing alike. Now, I want to say that I would expect anything you get asked about a thymoma to be a histology question. What do you expect to see under the microscope? or what type is this, because there's really not much else to go off of to ask you a question about in this SDL. Specifically, there's this line saying that thymomas have a pretty low mutational burden. That basically says mutation characteristic, there are no characteristic or defining mutations in thymomas. So they do stain for CD1A, TDT, CD3, CD45, CD99. So maybe the question gets asked, what would it stain for? But I would suspect it to be a straight up, by the book, simple histology play in which you have to recognize spindle cells versus polygonal cells. Take a look at some thymomas. Here is an anterior mediastinal mass outlined in red. And then I'll go to green, and you've got your aorta and your aortic root right there. Another thymoma. Here's your anterior mediastinal mass. And here is a big old lymph node swollen with metastasis, possibly. And that's behind the heart. And again, your aorta ascending and descending there. So that's the locality that we're in. Here's a type A thymoma. Notice how these cells kind of look like, I don't know, looks like somebody took a picture of normal epithelial cells and just stretched it out on the sides. That's what that looks like to me. Like saran wrap, you know, you just stretch and put it over whatever you're covering up. That's this type A thymoma. Then you have a type AB thymoma, which has A components and B components. Notice this thing is encapsulated. It's pretty totally encapsulated. It's a benign tumor after all. It's not invasive. Here's your part A component, which is lymphocyte poor. And then you also have a type B component, which is lymphocyte rich. And so the lymphocytes are these small purple cells. They're pretty round. They look like poppy seeds on a bagel to me. And you can spot them from just about a mile away because of their very dark nuclei. And again, spindle cells in the upper right there, they're stretched out, they're elongated, they've got tips to them almost. Use your imagination. So then we've got type B thymomas, and B thymomas are the polygonal cell thymomas. And I mean, we zoom in here and we can see these cells are pretty spread, you know, like they are there and they are letting you know that they are there. So that's the polygonal appearance. Very distinct from the type A's. And that's your thymomas, benign tumors. Again, not much to ask here about the histology or maybe the differential with the lymphoma. You want to use a CT scan to look at it. You can get compressive symptoms related to the location. You might see that recurrent laryngeal nerve, superior vena cava syndrome, dysphagia, dysarthria, cough, chest pain, SOB, dyspnea. So superior vena cava syndrome, how would that present? I think you'd see swelling of the lower extremities because of a backup of blood, hepatomegaly too, most likely. People also ask, let's see, face and neck swelling, JVD, cough and dyspnea, orthopnea. Oh, I'm sorry, superior. I was thinking inferior vena cava. No, yeah, superior vena cava. The blood backs up upwards, right? So of course you're going to see JVD, like duh, and then some like facial edema, periorbital puffiness, orthopnea, distended chest vein collaterals. So thinking about like the caput medusae, remember like with cirrhosis, you get those big engorged epigastric veins. The same thing could happen up in the chest and the neck. So that's going to be your superior vena cava syndrome. Blood backs up into the upper extremities and head. Thymic carcinoma. The takeaways. Number one, they tend to have squamous cell features. Number two, they're pretty aggressive. Number three, about half of thymic carcinomas have our friend Epstein-Barr, or maybe our enemy. Our enemy, that sounds a lot better. Our enemy Epstein-Barr virus is inside this cancer, and we got to go get it, right? So they also lack immature T lymphocytes. You see mature T lymphocytes for whatever reason inside the thymic carcinoma. The last big takeaway is the paraneoplastic manifestations of thymic cancer. Thymomas and thymic carcinomas, so let's make that clear right off the bat. Benign or malignant, you can get a paraneoplastic syndrome from a thymic tumor cancer. The most common paraneoplastic syndrome is myasthenia gravis, in which the cancer starts producing antibodies against the acetylcholine receptor. Now, let's go back one more time. I'm going to say this again because I think this is very important. Out of patients with myasthenia gravis, thymic follicular hyperplasia has been found in 70% of them, while thymoma is only associated with 10% of cases. So if they give you a patient with myasthenia gravis and they ask you, what is the most likely cause of this myasthenia gravis? And one answer is going to be thymic cancer straight up. And another answer is going to be something like B cell proliferation within the thymus, or like thymic follicular hyperplasia. You know, that's the right answer, not the cancer. So you could have that myasthenia gravis, paraneoplastic. You could also have a pure red cell aplasia, which is going to present as an anemia with normal platelets and normal white count typically. And how you know it's going to be, walk that back, not how you know, erase that. Characteristic to this pure red cell aplasia is going to be a low reticulocyte count. This paraneoplastic syndrome is so bad that you can't even make red cell precursors. So you're going to think it's a bone marrow problem if you don't catch this thymic tumor. Because anytime reticulocytes are low, what that reflects is the bone marrow isn't reacting properly to the anemia. You can have a paraneoplastic hypogammaglobulinemia. What does that mean? That means you've got low IgG. That's really bad because IgG is going to stick to a lot of different pathogens and opsonize them so that macrophages can eat them up. So you have an increased risk of infection if you have a hypogammaglobulinemia. And the reason why you might develop a hypogammaglobulinemia with a thymic cancer is, I have no clue where I was going with that. I'm really sorry about that. I made a note there like 3 or 4 days ago and it just went over my head. Oh well, happens to the best of us. Dermatomyositis, polymyositis, I did underline that. What I have to say about that is that remember that that is also an autoimmune presentation, and you're going to have endomysial inflammation in polymyositis, and you're going to have paramysial inflammation in dermatomyositis. So that likes to get thrown into question stems. A, endomysial, B, perimysial, you know. And so the way I remember that is that paramysial starts with a P, so does polymyositis. Keep them separated. No. They don't go together. So that's just how my brain works, you know. Just dumb little memory tricks like that. So dermatomyositis, polymysial inflammation, as well as heliotropic rash, right? Maybe around the eyes, periorbital, maybe on the neck, on sun exposed areas. What else could give you a rash in a sun-exposed area? Something to do with niacin, right? You get Casal's necklace. That's a dermatitis. I think that's actually one of 4Ds in pellagra, right? Isn't it? Dermatitis, diarrhea, dementia, probably one other. Yeah, but so you can get a vitamin deficiency. It can present kind of like a dermatomyositis. You can get a paraneoplastic Cushing syndrome. What is that? It's going to be hypercortisolism. So your adrenals are going to be overactive. You got a bunch of this glucocorticoid. And so you're going to have a persistently elevated blood sugar. You might get that moon facies, correct? And purple striae is very particular to Cushing. And also you're going to have an elevated blood pressure because corticosteroids upregulate the alpha-2 receptor. Maybe it's alpha-1. They raise your blood pressure a little bit. That's what I know. You could get an autoimmune pernicious anemia if you have a thymoma. What's that? It's an attack on parietal cells of the stomach, which make intrinsic factor. So you might have antibodies against parietal cells that kill those cells off. You might have antibodies against intrinsic factor that bind to that protein and stop it from binding B12. So you always, if it's allowed to continue, you will always get a B12 deficiency in pernicious anemia. And the reason it's called pernicious is because if you only treat the anemia and you don't catch the B12 deficiency, it'll come right back. No amount of iron or blood transfusion is going to correct this anemia in the long term because it's megaloblastic. So back before, you could just get an MCV and have it there quicker than a pizza, doctors had a real problem with this particular anemia. They really were stumped on how to treat it. And the answer is the patient needs B12. Rheumatoid arthritis, that's an autoimmunity. Again, you notice a trend yet? A lot of these different autoimmunities associated with thymic pathologies. You had rheumatoid, you had pernicious anemia, you had dermatomyositis, polymyositis, Myasthenia gravis. So rheumatoid arthritis, you know that. You got your knuckles involved. If the knuckles are involved, how are these? Metacarpophalangeal. If the metacarpophalangeal joints right there are involved, it's not osteoarthritis. No, it's not. It's rheumatoid. Graves' disease, TSH, anti-TSH antibodies, TSH receptor. Thyrotropin is another name for TSH. Tropin meaning grow. It's thyroid stimulating hormone. It makes your thyroid grows. Thyrotropin, TSH, same thing. You got a characteristic exophthalmos there. Your eyes are bugging out of their sockets. And you've got a hyperthyroidism with Graves' disease. So you can get that following a thymic cancer. So a ton of different paraneoplastic syndromes that you might see alongside a thymoma or a thymic carcinoma. And we've just covered the good majority of them in this text. They want to ask you about those. Definitely want to ask you about those. One more time, I think you'll get a histology question. I think you will see a thymic follicular hyperplasia question. Follicular lymphoid hyperplasia. You got to know that B cells like to make self-antibodies against the acetylcholine receptor. That's the most common cause of myasthenia gravis. You're going to get a DiGeorge syndrome question. And hypocalcemia is a big deal there. Patient doesn't have T cells. Patient's going to have a conotruncal heart defect. And you might see a positive or negative selection question. And that's about all that we have to say for now on the thymus. Thanks.